And the other side of that heart is what produces a reciprocal view, right? And different views of the heart produced by your limb leads and produced by your pericardial leads are what allow us to look at these coronary arteries in a bigger dissection, to help to identify what region of the heart is becoming ischemic or progressing into injury or already in an infarct state. So when looking at our 12 lead, the continuous leads are broken down into your 1 and your AVL, right? And if we think about 1 and AVL, we've got lead 1, okay? And then we've got augmented view left, right? So you've got augmented view left here. And the reason why they're continuous leads is because where they're looking at the high lateral portion of your myocardium, which is all primarily perfused by your left circumflex artery, right? The bifurcation off of that left main coronary artery from your left anterior descending to your left circumflex, okay? They're continuous leads because they're both looking at that high lateral wall that's perfused by your left circumflex artery. Now, looking at a reciprocal view of your high lateral would be your inferior wall, right? So you got your high lateral, now you've got your inferior wall. Your inferior wall, 80% of the time, is perfused by your right coronary artery, okay? 80% of patients, predominantly the inferior wall is perfused by the right coronary artery. Now, here is where we have a little bit of complexity, right? 2-3 and AVF is looking, so here's my heart, 2-3 and AVF is looking here. So yes, it's looking at the inferior wall, but it's looking predominantly at the left ventricular inferior wall, okay? If we think about the right ventricle makes up a portion of that inferior wall too. But based upon the views that are produced by these limb leads, we're not seeing much of that right ventricle. And the key here is your right ventricle is also produced or perfused by your right coronary artery. So when we've got ischemic or injury-based changes in our inferior leads, okay, I've got to move electrodes over, like do my V4R, so I can look at the inferior wall of my right ventricle to identify if there's ischemia or injury there, right? Because once again, my right coronary artery perfuses not only predominantly the left inferior ventricle wall, but also my right ventricular ventricle wall. Is everybody tracking so far? Nothing new, right?
I do have a question. This is Sam.
Yep.
So when you do that V4R, the only thing that I'm confused on, are you still looking at the same leads, 2-3 and AVF?
No, so all right. So V4R is essentially you can do this with any electrode, okay, first and foremost. You're taking an electrode and you're placing it on mid-clavicular, right, in the same latitude as your V4 normally goes. So you're essentially just moving it over. Now, we generally do V4, and then we just label that ECG as V4R, and we look at the V4 lead. If I move V1 from here to here, I would print out a Toby and look at V1, because now V1 is down here versus up here.
Okay, I get that now. Makes sense.
Good?
Yeah.
All right, awesome. So, once again, I've got my reciprocal view here, and I'm looking at my inferior wall, which is 80% of the time perfused by my right coronary artery. And because if I have ischemic or injury-based changes, ECG changes, I want to do a V4R to see if my right ventricular wall is involved as well. Now, why is that such a big deal?
For medication administration,
All right,
like
okay, you're on the
nitro?
right track. Be more, okay, so nitro. Why nitro?
Because it's a vasodilator, and if you dilate that left coronary artery, I'm guessing.
Well, it's going to dilate all of your coronary arteries, but it's also going to dilate systemically as well, right?
Okay.
So let's think about what your right versus your left ventricle does. And this is a big explanation in regards to your preload and your afterload. So your right ventricle, when your right ventricle contracts, it takes your end diastolic volume, right? which is essentially how much blood has made back to the myocardium in between beats, yes? And it squeezes that volume from the right ventricle to your lungs to be essentially oxygenated, right, through diffusion. And that squeezing is going to circulate that blood from the lungs, and it's going to come back to that left atrium, which is going to move down to the left ventricle, which now the amount of blood in that left ventricle prior to that squeeze, that's your true preload. So what produces preload? Well, one, the contractility and inotropy of that myocardium, the ability for the heart to squeeze and circulate the blood. The second component is your systemic vascular resistance, right? The tighter your vessels, the higher the pressure. The higher the pressure, the more blood that's going to be circulated back to your heart. So if I give nitroglycerin, okay, and causing systemic vasodilation, right, I'm going to have less pressure in my vessels, which is going to produce less volume returning back to that right ventricle. Now, on top of that, if I've got an infarction in my right ventricle, I've got less tissue contributing to that squeeze, yes? So now I've got less volume coming back to that right ventricle, and on top of it, I've got less squeeze taking place in that right ventricle, which ultimately is going to really diminish the amount of blood that makes its way back to that left ventricle, which when it contracts, it produces to the rest of the body, yes? So if I've got a right coronary artery occlusion that's affecting both my right and my left ventricles, not only can I not get enough blood back to my left ventricle, but being that my left ventricle is involved as well, my overall ejection fraction is low, so my cardiac output is really, 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 really shitty, which is why it can produce rapid descent into hypotension. Most likely that in the situation where you've got right ventricular involvement, your patient generally presents hypotensive already, where you're not even going to consider nitroglycerin administration because they don't meet the criteria as it is. But once in a while, we've got an inferior wall MI that includes the right ventricle, but they're normotensive. So we're in this realm of, okay, do I give the nitroglycerin? Do I withhold the nitroglycerin? I would withhold your sublingual spray or your sublingual tablet because that's a 400 microgram big time dose, and I would consider moving into your nitro drip, right, where we can start with 5 or 10 micrograms a minute, much smaller dose, where essentially 10 mics a minute, its half-life is about 10 seconds. So if I see a trending blood pressure start to come down, I can titrate my nitro off, and by the time I cycle that blood pressure again, it's right back up. So your textbook reads, nitroglycerin is contraindicated in your right ventricular involvement MIs. But in reality, from a clinical standpoint, you really have to base it upon what resources you have for medications, what routes that you have available to you, and hemodynamic where they're at right now. If they're hemodynamically stable and you have the ability to give a low-dose nitro drip, that's definitely a good consideration, right? Because I can get a little bit of coronary artery dilation here, potentially alleviate the rate of ischemia progressing to injury, and definitely slow down the rate of progression from injury to infarction, which is the name of the game, right? So moving right along here, so we've got our high lateral, we've got our inferior right coronary artery, moving into your V1, which is your septal with your V2. Your septal leads is your left anterior descending, which moves into your V3 and V4, which is also your anterior and also your left anterior descending. And then we move into the reciprocal views of your low lateral, right? So you've got your septal and you've got your low lateral, which is your left circumflex. So we've got reciprocal views here, and we've got reciprocal views here, okay? So if I'm seeing ischemia injury here, I'm going to look for reciprocal changes here. If I see ischemia injury here, I'm going to look for reciprocal changes here. Is everybody tracking, following along? Now, if I've got ischemia injury here, where is my reciprocal view, guys?
Posterior wall.
You nailed it. So if I have a little bit of ST segment depression in V3, V4, okay, and I don't see reciprocal changes anywhere else, which is common because none of these are truly reciprocal views, I've got to go move my leads to go find those reciprocal views, which is my posterior posterior view, which is your 7, 8, 9 essentially, right? So I'm taking 3 electrodes and I'm moving them to my back, right, to look at that posterior wall of the myocardium, which hopefully I'll find an ST segment elevation or depression depending upon what I have here, right? A true reciprocal change. Awesome, awesome, awesome. Is everybody feeling okay with views, reciprocal, continuous arteries that are associated? Everybody okay with that?